One of our mantras in the unit is, women aren't stupid. And that is always a good motto to live by.
Welcome to Transmission, the podcast of the Institute of Tropical Medicine in Antwerp. This season, we invite you to join our researchers in their never-ending quest for a healthier world. In the previous episode, we tried to conquer the hurdles the world puts in our way when we want to access healthcare. But as we'll discover in this third episode, you're nothing with access if it lacks quality, even for something as simple as cough syrup. Transmission, your front row seat to the world of health, science, and beyond. Diethylene glycol is a colourless substance that mixes easily with water and is used as an industrial solvent. You may be wondering why we're telling you this. Diethylene glycol is something you don't want in your body. If you swallow too much of it, your kidneys will stop working and you will die. Diethylene glycol can be a contaminant in the production of glycerin, and glycerin is used to make cough syrup. So much for the theory. Now the practice.
Last year in the Gambia, some 120 children died. Children younger than 5 years, they died of acute renal failure because they took this kind of contaminated syrup.
We are listening to ITM researcher Raffaella Ravinetto.
The first doctor who notified there is something wrong here did it in July. And it was only in October that these medicines was withdrawn from the market.
The Gambia case shocked people around the world, and investigators everywhere took a closer look at cough syrup.
And since then we had cases found in Indonesia, in Uzbekistan, in Iraq, in Cameroon, and in some islands in the Pacific.
Can you feel it tickling in your throat already? Do you feel yourself looking at cough syrup a little more suspiciously? Do you feel how quickly this story undermines your confidence in a simple medicine? That's the problem, says Raffaella.
You need to have a pharmaceutical system which works on quality, affordability, supply, etc., and which is trusted by people. And if people do not trust the system, then people will say, you tell me that this medicine is safe, but I don't believe you.
In most countries, if you go to a pharmacy, you buy medicine without asking too many questions.
We don't ask ourselves, am I buying a product which will deliver the promises in the label? I don't ask myself, is it safe? Will I get sick because of some impurity in this medicine? Or we just trust that somebody somewhere has checked all these things.
And in many countries, this is actually the case. There is a government agency that checks whether pharmaceutical companies are producing and marketing good quality medicines. But many countries do not have the resources to add such an inspection body to their health systems.
So, not having the capacity to make all these checks, there is the possibility that a medicine comes to the market even if the quality is not adequate.
Maybe the active ingredient, the substance that is supposed to make you better, is not present in the medicine in sufficient amounts, or the medicine may even be falsified. A few years ago, for example, ITM researchers and their colleagues from the Democratic Republic of the Congo took to the streets of Kinshasa to test the quality of antibiotics for children.
And the results were quite frightening. We found that 27% of the medicine tested in the study were seriously underdosed.
In other words, 27% of the drugs on the market simply didn't work. If you give them to a child, they're not going to get better.
And that's very dangerous because the child will not recover, but you don't understand why. You think it is because of the disease. Even worse, you think that because the mother didn't follow the good schedule. It's not the fault of the mother, it's the fault of the medicines.
How do we get to a world where we can provide everyone with quality medicines at an affordable price? This is the mission that Raffaella has set for herself.
Without that, you cannot achieve health, and especially not health for all.
But there are huge inequalities in the world. According to the World Health Organization, at least 2 billion people do not have access to medicines or are at risk of taking poor quality medicines. There's a lot of work to be done, and not only in the field of medications. If you don't have a whole battery of experts and quality services present, women die in childbirth. In some countries, maternal deaths are meticulously tracked. But in others, many mothers die outside the system, far from hospitals and doctors. The differences between countries can be huge. Countries like Belgium, Iceland, and the Netherlands top the list of countries with the lowest maternal mortality ratios.
These are the countries where we look at and say, this number is possible, this low level of maternal mortality is possible.
Lenka Beňová is an ITM researcher in reproductive and maternal health. She strives to get quality care for women everywhere.
Therefore, it can be achievable anywhere else. And all the additional deaths, all the excess deaths, are preventable. We have just chosen not to prioritize it.
A cold but accurate analysis. People are falling through the cracks everywhere. This must change. And that's why Lenka is working together with researchers across the globe. We have arrived in Lubumbashi, the second largest city in the Democratic Republic of the Congo, at the very bottom of the vast country, near the border with Zambia. Whichever way you look at it, Lubumbashi is a big city, a national economic and industrial center where more than 2 million people jostle for space with cars, motorcycles, trucks and minibuses, each with their own plans and perspectives. And somewhere in this hustle and bustle, Lenka is sitting on a bench with one of her Congolese colleagues. And they are counting. There is a big book on her colleague's lap.
We went together with one of the data collectors who now is sitting on a bench on a terrace in a small private health clinic with the register in his lap, and he's counting how many births there are.
His finger slides through the book. How many C-sections have there been? How many complications? How many deaths?
And as he goes through this very neatly completed register book, you are seeing on the side, a woman's name, of course, the birth weight of the baby, or 2 babies. You might have twins. Every month there might be 1 or 2 sets of twins.
But then,
and inevitably on every page, which might have 30 or 40 women listed there who gave birth, you will see 1 or 2 in the very last column that will say mortné, which means a stillbirth. And just having this in your face, page after page after page, you begin to understand both where this data come from, but also just how heavy this burden is in places that, where women are either not near the facilities, they are not able to afford the care on time, or the providers are unable to refer or give the quality of care.
Suddenly, they are no longer numbers, they are women.
Every single one of these numbers that we use, they all capture a life, a unique life, set of choices, set of non-choices that reflects a human being.
Women who were lucky, or women who left the hospital with unbridled sadness. But then Lenka noticed something else. The hospital where they were now sitting had added an extra column to the normal data, showing how much cervix dilation the women had when they arrived at the facility.
And so this is usually a number between 0 and 10. When you're 10 centimeters, you are, pushing.
In cities like London or Antwerp, you see a lot of women arriving with 2-3 centimeters dilation, with many hours of labor still ahead of them. But in this case, in this tiny hospital, Lenka kept staring.
I kept looking at that column and it would say 7, 8, 6, 9, very high numbers. And, when you look at the woman who arrived at 9 centimeters, the hour of arrival is 1850 and the time of birth is 1857. I mean, she just made it. And that could have 2 reasons. A is because there was trouble on the way, there was delay, she couldn't find transport. But there is another reason. Women don't want to be in health facilities that they don't trust. So they wait until the very last moment to sort of hand themselves over to this unfamiliar, hostile, unpredictable, uncontrolled environment.
A simple look at a birth register raises many questions. Why do women arrive so late? Is it because they don't trust the quality of the care? The inevitable has happened. A woman has died in childbirth. Now, as a doctor, you know that a whole machinery will be set in motion to make sure that doesn't happen again. And that machinery is set in motion with a meeting called a maternal death review, where all parties sit around a table to discuss what went wrong and how to prevent it from happening again in the future. A very useful activity, in theory, to raise the level of quality, but not so easy to set up. Imagine you are the doctor who was on call when the death occurred. Can you already see all the fingers pointing in your direction?
So there are, anecdotally, hospitals in China where maternal deaths are not allowed. The spirit or the motivation of that is good, right? Because what you're saying is, let's work together, make sure everybody's on board, that these deaths do not happen, that we, recognize them, treat them, we are prepared. Of course, what happens in that kind of situation is that the incentive will be, if something happens, if a maternal death happens, it will be in everyone's incentive to hide it rather than to learn from it.
And so you arrive at one of the biggest obstacles for a world with fewer maternal deaths. We should learn from every death, but
practically it's incredibly difficult because the blame and the shame and the sadness around the death is hard to manage, right? So it's much easier to say, well, it was his fault for not being here. He was on call. Why wasn't he here in the hospital? As opposed to thinking about the health system.
Changing an entire system is difficult, takes a long time, and requires a lot of work from everyone involved. It is easier to point to an individual doctor. Christelle Boyi Honsou is an ITM alumna and now a researcher at the Center for Research in Human Reproduction and Demography in Benin. She made it her mission to approach these reviews differently in order to reduce maternal deaths in her home country.
We can say now in Benin that we have about 7 mothers who dies daily while giving birth within the 42 days after delivery.
In 2022, the country recorded more than 1,900 maternal deaths. However, many deaths are not reported because women may die at home or after an unsafe abortion without the involvement of the formal health system. This leads to estimates as high as 2,500 maternal deaths, and despite substantial government efforts, this figure ranks Benin 13th in the world for the highest maternal death ratio. Christelle hopes to turn the tide. It is a challenging task because hospitals are understaffed and people get stuck in their ways. As a result, review meetings don't always go smoothly.
And these sessions are expected to be conducted with the principles of the no-name, so nobody should know who the main provider who gave care to the woman, for example. It is expected that no blame should come after this review. Whatever is found to be the factors that led to the death.
But the reality is often different. It's hard not to feel blamed during the maternal death review sessions, and many factors are at play. As a result, the real problems that led to the women's death are usually not correctly identified.
So you will come up with a different solution, but perhaps not addressing the problem that is there on the big level. And then it's easier to say, well, we didn't have blood, or that person wasn't there, or even worse, the woman came late, right? So now it's her fault that she died, or her family's.
But more often than not, the story is much more nuanced, as Christelle and her colleagues discovered when they were researching maternal deaths and the review process. Somewhere in Benin, a pregnant woman died. No, not on a delivery bed in a hospital. She died at home, in her village, away from the hospital. But why there, when there was a big hospital nearby that could have helped her? In a normal review process, the answer would be simple. Everybody would gather around the table and point to the woman who didn't come to the hospital. Stupid woman. Not our problem. Case solved. But as Lenka says,
one of our mantras in the unit is, women aren't stupid. And that is always a good motto to live by.
So why didn't the pregnant woman get to the hospital in time? Her baby was stillborn. Did that play a role? During their research, Christelle and her colleagues discovered that sometimes midwives delayed calling the gynecologist for a cesarean section. They did so with the best of intentions. They didn't want the women to lose their babies and have to deal with the cesarean section.
They just try as much as possible to help this woman to deliver, to have a vaginal delivery.
The result of this well-meant action? More women died in childbirth while delivering their stillborn babies. But it wasn't the fault of the midwives either. In this particular case, it was an issue of trust between the different parties that were involved. Something that's hard to figure out during a standard maternal death review. Fortunately, Christelle and her colleagues co-developed a new review model that looks at the underlying patterns and structural issues. This new model also includes near misses and the mindset of the different healthcare workers involved in the care of women. After very successful pilot projects, Christelle's next step is to talk to policymakers to hopefully implement her new review model across the country. In doing so, she's having a very tangible impact on the quality of care and the number of mothers who die in childbirth.
Now I can say that I'm proud of that because I'm proud of the way people feel during the implementation, the piloting of this model. And we are convinced that if we act on this, it will surely reduce maternal death in our institution.
The stories are compelling. The work seems endless. Christelle and her work made a real impact, and that's what keeps her going. Every researcher has such a flame burning inside. What would Lenka Beňová say if people in a bar asked her what keeps her motivated?
Actually, I would tell them my own story, to be perfectly honest, is when I gave birth myself, I developed not a serious but a very painful condition about a week later. And I had to be readmitted to a hospital for some treatment for a couple of nights. And when I arrived at the hospital, and this was in London, it's irrelevant where it is because this is a story that is very much global. The point of the story can be placed anywhere. And this was a busy inner London maternity ward. And of course, everybody was very busy taking care of women who were giving birth at that time. So to get diagnosed took many hours because every set of doctors that came was immediately called to some other woman who needed their attention more. And so by the time it was the nurse came to take some blood for the lab, I was so tired and stressed that she couldn't actually get a drop of blood out of me. She couldn't find my vein. And she walked away frustrated. And a midwife came, and I'm just inside in a very busy ward, covered, just with curtains. You can hear every other woman on the floor. And she came and she touched me and she looked me in the eye and she said, "Can I make you a cup of tea, love?" And I said, "Yes, please." And she brought that cup of tea and a buttered toast. And it was the most kind gesture that I have ever felt from a health system. And I'm tearing up now, you can see it, huh? But it was just the way she looked at me as a human. And she said, "Gosh, this lady is exhausted and stressed. We're not going to get an IV line in her unless she relaxes." And I wish that for every woman, that she's seen as a full human being, not just a womb, not just a contraceptive, not just as a problem, but to be taken care of kindly and humanly in a health system that can meet even social, psychological support issues.
So that's the story Lenka tells people over drinks when they ask about her motivation.
I'm not much fun in bars, eh?
Do you know the story of the canary in the coal mine? Miners used to take a canary with them underground. The bird was supposed to warn them of a lack of oxygen or if toxic gases were released during underground digging. The bird did not do this by whistling a warning song, but by dropping dead. When the fragile canary died, the miners knew that something was wrong and that they should leave the mines as fast as possible. A dying mother is the canary in the coal mine of our healthcare system.
When a pregnant woman dies, we know something is wrong in that system that didn't take care of things the way that it should have done.
It is a powerful signal that something needs to change. When a country gets its maternal mortality under control, it means the quality of the whole system is improving.
Because to take care of a woman in her reproductive life who is pregnant, who is giving birth, who needs postpartum assistance, who might need family planning again, you need the entire range of services, starting with community awareness, community distribution of bed nets, to primary care services, for example, immunizations, antenatal care, measuring of blood pressure, measuring of the growth of the baby, all the way to extremely advanced hospital-level care, which is, for example, cesarean sections, blood transfusions, care for rare and intense complications that women endure.
There are many obstacles in our path. You shouldn't have to worry about the quality of your medicine or whether a hospital will treat you safely. But all over the world, people do, all the time. We need quality healthcare before the canary dies. Thank you for listening, and join us for the fourth and final episode of this season as we delve deeper into the question of how you can prepare your health system if you don't know what crisis is coming. The answer lies within all of us. We must become more resilient, but that is easier said than done.
And I heard some people talk about what we'll do now is prepare for 100 different kinds of crises, so that we have a crisis plan for each shock that will happen, which is nonsensical.
For more information about the Institute of Tropical Medicine in Antwerp, visit itg.be/podcast.